I will start with the topic for today, which I will talk about PHEOCHROMOCYTOMA and PARAGANGLIONOMA, and I will cherry pick because of such a vast topic. It's impossible to cover in 15 minutes or so. So my target audience is the patients and caregivers, and I have no disclosures except that I'm endocrinologist. So I'll start with the basic terminology, which is a little bit different from terminology of NET. First of all, PHEOCHROMOCYTOMAs and paragangliomas are neuroendocrine tumors, and they arise from chromaffin cells. They are rare tumors with common embryonic tissue origin as NETs. And we use PHEOCHROMOCYTOMAs and paragangliomas terms interchangeably because they have a very similar clinical presentation and sometimes behavior, but there is one distinct primary difference between them, and the difference is in location. So PHEOCHROMOCYTOMAs arise from the inner portion of adrenal gland, which we call adrenal medulla, and paragangliomas arise from the special structures that are called ganglia. I will use for the brief term PPGL when I speak about both PHEOCHROMOCYTOMAs and paragangliomas. Now, both structures, inner part of adrenal gland and ganglia, are important structures in the autonomic nervous system. And to understand the behavior of PPGL tumors, it's important to understand the function of autonomic nervous system. And the key word in this term is autonomic. Autonomic, it means involuntary, something that we cannot control with our mind. And this is part of a neural network that coordinates internal body organ functions. So you see here a picture of this careful balance that this neuronal network performs between different needs of our body, the state of rest when we rest, heal, and digest, and we call it parasympathetic activity, and the state of fight and flight. So when the body needs to operate on the different level in the situations of stress, then the sympathetic activity dominates. So, and this is a diagram of a sympathetic system. You see the brain, the spinal cord, and you can see this network of nerves that transmit electrical stimuli to the different organs and activate them. So the organs that we are not controlling with our minds, which are activated by sympathetic or parasympathetic parts of these autonomic nervous systems, are heart, lungs, gut, liver. So those are almost all inner body organs that function according to the signals that they get from the sympathetic and parasympathetic systems. And those electrical stimuli, finally, when they reach the organ, they translate it also into the chemical stimuli. And the chemical stimuli for these particular systems are hormones, which we will talk about later on, adrenaline and noradrenaline, or we also can call it epinephrine and norepinephrine. So you see here in the middle between the peripheral inner organs and the spinal cord, this special control units that we call ganglia, and they're located in the middle of it as a control centers to regulate the function. And here I'll show you some, I want to show you some examples of tumors that arise from those structures that we call ganglia. So you see the structure we call that all ganglia are connected by nervous tracts, and they spread from the base of the skull through the neck, through the thorax, abdomen, and into the pelvic part. And you see here example of head and neck paraganglioma. The first picture you see is, I cannot, there is no pointer, no.
No?
Pointer.
Pointer?
So,
yeah. Okay, try this.
Okay, thanks. So you see on this picture, you see the paraganglioma behind the eardrum. So this is a paraganglioma of the base of the skull. And here you see the bulging on the neck of this lady. And this is an aortic body carotid tumor. So those head and neck paragangliomas are part of a parasympathetic system, and down the sympathetic, down this nervous tract, there is a sympathetic system in thorax and abdomen and pelvis. And you see here an CT of thoracoabdominal paraganglioma. And the biggest ganglia, we call it organ of Zuckerkandl. Now, so paragangliomas can occur in multiple sites in the body, and PHEOCHROMOCYTOMAs, as I already mentioned, we call them according to the location, the tumors that arise from the inner portion of medulla. Usually, the tumors, PHEOCHROMOCYTOMAs originate in the posterior portion of the thorax and the abdomen, and we cannot palpate them on physical exam, but they manifest themselves through the secretion of hormones. And the main hormones are epinephrine and norepinephrine, and collectively we call it by term catecholamines. And there are also more molecules that we use for diagnosis, which are metabolites of those hormones, and that are called metanephrine and normetanephrine. So when the tumor secretes an excess of catecholamines, those catecholamines are spread through the circulation into the different inner organs of our body, and cause and this and excess of hormones manifested as the symptoms. So the main symptoms of PPGL tumors are high blood pressure, headaches, rapid heartbeat, and sweating. And we call it classic symptoms of PHEO and paragangliomas. But some patients are not presented. Actually, even majority of the patients are not presented with those classic triad of PHEO, and they can present with gastrointestinal symptoms, for example, weight loss, abdominal discomfort, constipation, nausea. Some of the patients can present with neurological symptoms and even psychiatric symptoms. Often patients get misdiagnosed as panic attacks, and they're going to be nervous or tremors. Some patients develop chest pain, and this is the first presentation of PHEOCHROMOCYTOMA or paraganglioma, can be myocardial infarction. They often are pale, they feel weak. In some patients, there is an elevation of blood sugar, heat intolerance, and abnormal response to certain medications, for example, steroids that can cause the secretion of the surge of catecholamines in the blood circulation. Another characteristic manifestation is a PHEO attack, or we call it also spells. Those are episodes of sudden symptoms caused by a rapid influx of catecholamines into the blood system. And the duration of these attacks are usually less than an hour. Usually it's 20, 30 minutes. The frequency varies as frequently as daily attacks, or it can be once every few months. And usually the spells are unpredictable and can occur spontaneously, but sometimes it can be triggered by stress, strenuous exercise that increases abdominal pressure, such as lifting or straining, a variety of medication, foods, or surgery for unrelated reason. And we see here a graph with the spikes of blood pressure in a patient during a 10-day period. So the uncontrolled blood pressure, that elevation can be sustained and patient is diagnosed with hypertension, but sometimes the elevation of blood pressure can be paroxysmal just during those attacks. I want to say that it's very important to early diagnose PHEOs and paragangliomas, especially those that are secreting, because as undiagnosed disease progresses, the catecholamine excess and symptoms also cause additional problems, and in some cases can be catastrophic. If untreated, PPGL can be fatal. They can cause heart attack, stroke, arrhythmias, malignant hypertension. So it's a hypertension that is associated with organ failures. We call it PHEO crisis. And of course, in cases of tumors with greater malignant potential, undiagnosed disease can result in tumor metastasis. When we suspect PPGLs, so I told you about paroxysmal symptoms or PHEO attacks. Another group of patients are patients with resistant hypertension that are uncontrolled hypertension on several antihypertensive medications. Hypertension once at high blood pressure once at a young age, abnormal blood pressure in response to drugs or anesthesia or surgery, family history of PPGL. I will stress this point later on. A known syndrome in patient or family, first-degree family member that predisposes to PPGLs. And also the one important population are patients with this incidentally discovered adrenal masses. And we know now from the recent publications that about 25% of PHEO diagnoses are started evaluation and were diagnosed after the patient performed CT or MRI due to unrelated reason, and adrenal mass was found and was later diagnosed as PHEO. The diagnosis and imaging of PHEO is pretty straightforward in most of the cases, especially when we have good biochemical tests. The main test that we use is a collection of urine and testing those hormones, catecholamines, or their metabolites, methanephrines, in urine. And we also can use levels of those hormones in the blood. The specificity, our certainty that the diagnosis of PHEO can be confirmed is great, is elevated with the levels of catecholamines. So usually level of catecholamines 3 times upper limit of normal, we're pretty certain, and we continue to the next step, which is looking for the tumors that secretes this excess of hormones. And the first imaging test usually is CT. In children, it can be MRI. There are also some functional imaging tests, PET CTs, such as somatostatin imaging, FDOPA-PET-CT or FDG that we usually use when we suspect metastatic disease. If we think about our understanding in the recent years of PHEO and paraganglioma genesis, so how those tumors actually develop in our body, we should stress the importance of genetics. We see here on this graph from early 90s up until recent years, the different genes that were discovered that called disease-modifying genes. Those are genes involved in formation, development of those tumors. We know already about over 20 genes, 22 or 23 genes are discovered, and they are actually involved in about 40% of cases of patients with PPGL. And I'm talking about germline mutations, those mutations that can be inherited and passed to the next generations. When we try to see how those genes are involved in the processes, in cellular processes, so how those genes actually cause disease, how they cause cancer, here we still have many uncertainties, but we start and try to elucidate and to classify those different genes according to the different pathways, and the three pathways that usually disrupted in some way due to the mutations in those genes are pseudohypoxia, Wnt signaling, and kinase signaling. I'm mentioning it because in the future we will find we will find the way to modify those pathways and treat those tumors. So the genetic role is really playing an important role in understanding tumors and understanding the way how to treat them. So this is just another representation. I wanted to stress here that we know that some of those genes, in some of them, mutation cause some of those genes are oncogenes, and so they drive the formation of tumor, and in some of those genes are tumor suppressors. So the mutation actually deactivates the gene and starts the formation of the tumor. So the oncogene example here is a red gene, red proto-oncogene, which is a driver in multiple endocrine neoplasia type 2 syndrome. And the tumor suppressor gene example is ADHP, which accounts for about 40% of metastatic PPGLs. As I already told you, PPGL has the highest degree of heritability of any other endocrine tumor type. As the germline mutation occur in about 40% of patients with PPGL, and the genetic testing is important. And it's important as for the index patients, the patients that was diagnosed with the disease, and also for family members, of course. The patient needs to know if he has a genetic mutation, because it can predict the development of another tumor in different location. It happens in about 10% of the cases, and it's associated with it usually happens in a younger age, and when the first tumor was found to be extra-adrenals, it means paraganglioma. And also if the germline mutation is known. The risk of metastatic disease is also increased in several genes that we know, and it's SDHP, FH, and MDH2. And I want to show you here the recent publication about the positive impact of genetic testing. And this group looked at the historic group of patients with PPGL that weren't genetically tested, and versus patients that were diagnosed through the genetic testing. And you can see that the patients in the genetic group, they have a smaller primary tumor. Smaller means easier to treat, to cure, to resect. The complication rate was also small, much more small, less in the genetic group. And of course, the most important thing is the survival of the patient that were diagnosed earlier through the genetic testing was impacted. Several words about the surgery. The surgery plays a crucial role in treatment of PHEOCHROMOCYTOMAs and paragangliomas, because most of those tumors can be resected, and whenever those tumors are located and could be resected, they should be resected. The surgery involves usually laparoscopic total adrenalectomy. In some cases, in familial cases such as VHL syndrome, we usually prefer cortical sparing adrenal surgery because of the higher incidence of bilateral PHEOs. The important part is an experienced OR team. Surgeon and anesthesiologist is crucial for the safe surgery. And we also use antihypertensive medications that know to block the effect of those hormones, and we call them alpha blockers. Sometimes we use other different families of antihypertensive in cases of uncontrolled hypertension, and try to control medically hypertension before the surgery. The surgery as itself, the tumor manipulations and anesthesia that is administered can be very tricky during procedure of tumor removal. In a smaller percent of cases, but still a very important group, are those patients that are diagnosed with already metastatic disease. So unresectable PHEOCHROMOCYTOMAs are usually occur in 10 to 15% of patients at the time of diagnosis. This tumor progression is usually the most common cause of death, and also the symptoms that related to hormonal excess cause up to 30% of malignant PPGL deaths. So in those patients, our main goal is to control tumor growth and reduce symptoms. And here we can say is that in this kind of patients, in individualized treatments and individualized approach is very important. Some patients can be candidates for surgery debulking, so removal of dominant parts of tumors to reduce effect of hormonal excess. In some patients which are candidates for targeted radiotherapy, we use treatments such as PRRT or radiopharmaceutical such as Azetras, which was approved about 2 years ago in the United States. other treatments such as somatostatin analogs, different ways of ablation of tumors, chemotherapy, or other drugs such as tyrosine kinase inhibitors are still they are used. We see the case reports, we see small series of patients that were treated and successfully treated with those therapies. But as I already said, it should be the decision should be made by a multidisciplinary team, and it should be individualized according to each case differently. So the systemic therapy, which seems effective and useful from what we have now for metastatic PPGL, are targeted radiotherapy, which includes radioactive particle bound to specific molecules that has an access to the tumor cells. And we have two kinds of treatments, as I said. First is PRRT, and the second one is an azedro, which is an analog of norepinephrine bound to the radioactive particle. And here we have several studies that were performed to see the efficacy of those radiopharmaceuticals in patients with PPGL. So for PRRT, in the majority of the cases, we see the response as stabilization of the tumor growth. In about a quarter of patients, we see partial response, and there are also a component of patients that have a progression, about 12%, if we combine all the data. And the recent study was also the phase 3 trial that showed the efficacy of azedra in the 64 patients and showed quite similar results as we saw with PRRT treatment. So we can use those treatments for metastatic PPGLs. And to conclude, the takeaway message is that PPGLs are rare tumors, but they are not so rare in specialized centers, and that's where those patients should be treated. There is a high mortality rate with a delayed diagnosis or inappropriate treatment. Most PPGL patients with PPGLs can be cured. An experienced operating team is critical for the safe surgery. Genetic testing is strongly recommended in all cases, and lifelong follow-up is warranted. And of course, individualized approach for patients with metastatic PPGL is needed. Thank you very much for your attention.